Hello, this is Jonathan Busco, and I'd like to talk to you today about a concept that I call the practitioner gap. This is a real threat to healthcare in a lot of communities, but it's also an opportunity for us to innovate in the way that healthcare is delivered. I want you to think about practitioners in health services delivery, and I'd like to cover a little bit of history to give it context in terms of what we're seeing today. Before 1910, it was really anything goes. You had lay providers, you had unregulated physicians with erratic and different levels of training. And yet even in those times, there were still practitioners whose sole job was to extend physicians' practice, like feldshers or barber surgeons, the loblolly boys, or the practicantes. In 1910, everything changed when Abraham Flexner released his report on medical education and the state of medical practice. And after that, the focus turned front and center to the physician practicing evidence-based medicine. So if you think about practitioners of that time, you had many lay practitioners, relatively affordable. You had physicians, relatively expensive, and somewhere between them were midwives who were practicing fairly independently in their own specialized area. In the 1930s, Dr. Higgins trained Eddie Rogers to be his urologic surgery assistant. And the health service, recognizing a lack of practitioners to care for prisoners in federal prisons, brought in formal naval corpsmen to provide that care. All of this happening under physician oversight and on the direction of physicians. In the 40s, it was realized that there were real challenges in delivering health care to the Alaska Native villages, and so the Alaskan Community Health Aid program was born. Dr. Johnson in North Carolina trained Henry Treadwell to be his doctor's assistant, essentially functioning as his hands when he wasn't there. The Maritime Service trained pursers on ships during World War II with some additional medical care, advanced medical care, knowing that they were in situations where there was no other support and they were fairly inaccessible in terms of any more advanced practice than that. And so they practiced by extension of those physicians. And as the war went on and physicians became a scarce resource, the Army battalion aid stations went from staffing with 2 surgeons to 1 surgeon and 1 battalion surgeon's assistant. So if we think about the practitioners of that, at that point, you had these certificate, high school diploma type practitioners who were true physician extenders. Their role was to extend the practice of a given physician. And then you had physicians. So fairly large gap between the two. Now in the 50s and 60s, particularly as Medicare was rolled out, it was realized that there was a real shortage of primary care physicians, particularly in rural areas. So in 1957, the first master's level nurse clinician program was launched at Duke. Now, unfortunately, the National League for Nursing did not accredit it. And so rather than giving up on this idea of being able to provide a practitioner to these rural areas that were challenged, the Duke clinicians turned to the idea of physician's assistants. And in 1965, they started their first program, and the first students were former naval corpsmen. Now, ironically, in 1965, the first certificate nurse practitioner program was also launched at the University of Colorado, 8 years after the idea had initially been floated by Thelma Ingles. At the same time, in the late 60s, state licensure boards were really cracking down on the informal physician extender arrangements. So those physicians who wanted physician extenders and those people who wished to extend a physician had to look to these more formal programs to validate their practice. And so some baccalaureate level PA programs began to emerge. Now, as a parallel, prior to the mid-60s, there were emergency medical services, but they were mostly delivered at the first aid level of care with transport of patients. And so Frank Pantridge, who was a physician in Ireland, wanted to bring physician-level care to the field in EMS. And he did so by physician staffing a mobile coronary care unit, which basically brought defibrillation and medication to the patient's side during cardiac events. This was a breakthrough concept in where care could be delivered, but it was still physician-centric. So if we think about practitioners at that point, you had these community health aides practicing at the high school diploma level essentially, and then at the bachelor's level, PAs and nurse practitioners who were moderately expensive, and then at the doctorate level, physicians who were much more expensive. So in the 70s, things began to change. In 1970, California became the first state that enacted a PA enabling law, and a number of other states followed. And those laws focused on physicians delegating their practice to trained assistants. So those assistants were to be physician extenders. The PA programs focused very much on clinical algorithms to guide care with very tight oversight. The nurse practitioner programs expanded to the master's degree level, and although they'd initially focused on pediatrics, quickly expanded to many other populations as well. In 1977, Medicare reimbursement for PA and nurse practitioner practice in rural clinics was instituted, and so now there was a way to pay for their practice through the Medicare system. In the early 70s as well, there was a shift in EMS, and that shift was the introduction of the paramedic. So before, you just had first aid trained people who essentially did basic stabilizing care and transported patients. In this model, with the national standard curriculum, you now had paramedics who could be the hands to physicians' minds and deliver physician-level interventions in the field: intubation, defibrillation, medication administration. So if we look at the end of the 70s at what the practitioner landscape looked like, now you had at the certificate level, the high school diploma level, paramedics and community health aides, a relatively inexpensive resource that extended a physician's practice. At the bachelor's level, you had PAs, the master's level, nurse practitioners, and then physicians at the doctorate level. And the costs went up accordingly. The bachelor's and certificate levels were still physician extenders. PAs at that point were still primarily assisting physicians in the care of their own patients. Now in the 80s and 90s, there was a radical shift. As anyone in the legal system or any psychologist will tell you, apostrophes matter. And so when the name of the practice went from being a physician's assistant to a physician assistant, that changed the role of those practitioners. No longer was the implication that a physician's assistant was assisting a specific physician in the care of his or her patients. Instead, the role itself was the physician assistant. Medicare Part B reimbursement was extended to hospitals for PA practice, and the military expanded its use of PAs as well. In fact, they became commissioned officers. At this point, the PA programs, the enrollees had moved away from former military corpsmen, medics, and the general public was very interested in this concept. So people coming to these PA programs often had bachelor's degrees. And so that led towards a trend for the awarding of master's degree for these PA graduates. Now at the same time this was happening, two things happened in the 90s that were very important in terms of this physician extension practice. The first was in the late 80s, the community health aid program went through some tumultuous times, and so it redefined itself. And it redefined itself very strictly as physician extension. There were textbooks with protocols built into them. There was rigorous oversight and retrospective case review. And using telemedicine in combination with those other practices, the community health aides were able to significantly expand their practice and deliver many more services in the villages without having to move patients. At the same time, in a small town called Red River in New Mexico, a collaboration between some University of New Mexico physicians and the Red River EMS service looked to that type of model and that type of oversight without the telemedicine and demonstrated that with tight oversight, with tight case review, paramedics could actually deliver acute or urgent care level care, not just emergency care, with good outcomes. Unfortunately, in the late 90s and early 2000s, the interest in that dropped off from an oversight perspective, leaving the paramedics to practice fairly independently at a very advanced level. And those outcomes were not so good, demonstrating that that tight bond between the physician and the physician extender with strong oversight was critical at that level of practice. So I want to talk a little bit about paramedicine, and that's a word that gets bandied around. It has different meanings to different people. To me, it means something very specific that's very relevant to this discussion, so I'd like to define it. So it's a unique practice of medicine, and the care delivered by paramedicine practitioners is directed entirely by an overseeing physician. The paramedicine practitioner cannot do anything that an overseeing physician has not directed them to do, either directly through real-time medical direction or asynchronously through protocols, usually very prescriptive protocols. So that's really differentiates this practice from that of a PA or a nurse practitioner who may have a supervising physician and a plan of supervision that generally says what they can do, but who is not treating each patient under very prescriptive protocols. Secondly, the care in paramedicine is delivered remotely from the location and the practice of the physician. So this is as opposed to a medical assistant who usually is practicing at the same location as the physician and always is caring for that physician's patients. Paramedicine practitioners will develop a clinical impression or a presumptive diagnosis, and that's a medical diagnosis that then guides them on which protocol to select and follow, as opposed to nurses who develop nursing diagnoses, but in terms of care of patients, have to rely on a practitioner to develop a medical diagnosis and come up with a plan of care that the nurse then executes. This care is 100% reliant on the communication between the physician and the paramedicine provider. If there isn't a physician directing the care, either directly or asynchronously, the paramedicine practitioner cannot practice. And that care is delivered as part of an organized system of care. So a paramedicine practitioner can't just hang a shingle. They have to be part of a much more substantial system of care that wraps around the patient, of which they play a very specific role. And finally, and this isn't unique, like all other professional practitioners, as medicine evolves, so do these lifelong learners. So where do we see paramedicine practice? Well, most of us think immediately of EMS, paramedics in the field doing mobile emergency paramedicine. In this day and age, we may think of community paramedicine or mobile integrated health, where there's some health care or some home health care, some community care delivered by paramedics. But there are also paramedicine providers who are delivering a combination of emergency, public health, and industrial paramedicine. And those include the medical person in charge on a commercial vessel regulated by the International Maritime Organization, or industrial and resource extraction medics like those on oil rigs or remote sites. And then there's some full spectrum paramedicine practitioners, the Alaska Community Health Aides and now Community Health Practitioners, and the United States Navy Independent Duty Corpsmen, who will provide a full spectrum of care, but within the constraints that we discussed that define paramedicine practice. So, the end of the 90s, if we're looking at the practitioners now, we've got physicians, expensive resource. The master's level PAs and nurse practitioners, a little less expensive. PAs at the bachelor's level still. And then these certificate or GED level, very specialized physician extenders, the community health aides and the paramedics. So then from the 2000s to the present, we see PA practice spreading around the world and master's programs becoming standard. PA doctoral programs come into existence that recognize postgraduate clinical training. And there's a movement towards autonomous PA practice. At the same time, EMS looks into mobile integrated health or expanded scope of service or community paramedicine, whatever you want to call it, with a focus on population health and primary and preventive care. And although there are associate and even bachelor's paramedic programs, unlike the PA doctoral programs, which recognize additional clinical training, the bachelor's and associate's programs don't add clinical training beyond the certificate program for a paramedic. So if we look at our practitioner gap now, we've got at the doctorate level physicians, PAs, nurse practitioners who may be very expensive. There are rural hospitals in the United States that are offering PAs comparable rates to physicians to staff their emergency departments. So there's no cost savings there. At the master's level, you have PAs and NPs in this fairly autonomous practice. They may have plans of supervision, but they are essentially caring for their own patients. And then you have this very large gap to the certificate level program. So that's where we're at. We've got this big gap between master's level practitioners, fairly autonomous, and these highly specialized certificate level programs in these practitioners who are still physician extenders, what the original vision of the PA was. Now, the Alaska Community Health Aide and Community Health Practitioner model has demonstrated that paramedicine model could be very effective. The advances in telemedicine, the ability of physicians to deliver remote care through the hands of trained professionals has been clearly validated as effective. And so, given all of that, I think it's time for us to re-examine the role of the physician extender, and that's what I ask all viewers to think about. What would it mean to be a true physician extender today, where practice is delegated? That is, all practice falls under the paramedicine model. It is the practice of a physician extended through the paramedicine practitioner. What could we do with that in this day and age of training, telemedicine, and our electronic health records and our electronic imaging systems that allow us to share information instantaneously, when we can train practitioners remotely to be able to be the hands of physicians' minds? That's what we need to consider. Thank you for your time.